Let's talk about MTHFR, another mouthful, methylene tetrahydrofolate reductase. What happens in normal methylation cycle, and this cycle was actually a lot messier than this, even though you think it's a lot, but I've left the things that are significant for us to understand. What I want people to know is that medicine is really simple because it makes sense. If you understand where things begin, you know how things can go wrong. And it doesn't change. You know, the methylation cycle is the same. And people always ask me, Doc, can I get a new genetic test? Maybe it's changed. I'm like, no, you're born with it. It's science. You know, nothing changes. It's that when you have environmental factors, stress, all those things can make this, even if you don't have MTHFR deficiency, it can cause problems. So let's talk about this, beginning with folate, folic acid found in your food. Goes through the folate cycle, and methylene tetrahydrofolate reductase makes it to L-methylfolate. And we know about the L-methylfolate, but do we understand the rest of the cycle? You have to understand the rest of the cycle in order to really explain to the patient why you need to take those medicines. Some of them like, it didn't do anything for me, and I took it for 2 weeks, and I'm like, no. I always tell my patients, in my clinical practice, I have seen results. You got to give it a good 3 to 6 months because we're not treating the patient with a Band-Aid. Band-Aids can work a little bit quicker, yes, but treating the underlying cause, that is going to take some time to get the results that they're looking for. However, you can tell the patient if they are not having any problems with medication, they're tolerating it, and they may see a little bit of improvement, I don't know, a month into the treatment. That means, guess what? We treated the underlying cause. And you know what? You're going to get those long-lasting results. You're not going to get that 50% failure or 25 or 2/3 because we have found what was wrong with them in the first place. So if you look at the L-methylfolate, you have the other cycle, methionine. Part of that cycle is homocysteine. So this is the fun one because this is just not about psychiatry. Cardiologists check homocysteine, and I think a lot of us clinicians here have a medicine background before we went into psych. Myself, I did. I actually did 1 year of dual training, internal medicine, psychiatry, and I love the science of internal medicine, learning about pathophysiology and regular physiology. And then I found that the practice of psychiatry was really where I belonged. And I'm so glad I never lost my love for just general medicine, the theory, because it helps me put the pieces together and how to help the patient. So homocysteine with L-methylfolate becomes, in general, SAMe. And SAMe will interact with tryptophan or tyrosine. If you go tryptophan, that makes serotonin. If you go tyrosine, that makes dopamine. And dopamine does also break down to norepinephrine. It makes all the good feel hormones. You need enough serotonin to keep things balanced. You need enough dopamine or epinephrine so you can focus and you're not depressed. Let's talk about what happens if you have too much homocysteine. Too much homocysteine in general. Cardiologists check this. Neurologists can check this. If it's high, it's a problem, right? Causes inflammation in the brain, suppression of neural stem cells. It stops it from growing, and it destroys the blood vessels. It causes breakdown of the neural cells. It stresses the cells with oxidative stress, and it impairs myelination, as well as causing plaques and tangles, which is what we see in Alzheimer's. So a lot of people just minimize and don't think this is significant. But if you show them this cycle, it is. And it's not just relevant to psychiatry, it's relevant to general medicine. Let's talk about MTHFR deficiency. So we know how it happens, and these are the mental health consequences. If you look at depression, anxiety, ADHD, addiction, eating disorder, you can pretty much pick and choose which neurotransmitter is deficient in each of those. And having MTHFR deficiency can explain that, because these people will have a decreased amount of their normal neurotransmitter that makes them feel good. I do want to say that in clinical practice, you can be MTHFR deficient all your life. But as you know, in life, lots of things happen: stress, brain injuries, environmental toxins, and just different things in life that causes us to essentially have a quote unquote mental breakdown, even menopause, right? You may have not dealt with that all your life, then all of a sudden you are crashing. And this gene, the deficiency in this gene, can explain why that happens. Taking away the blame from the patient again, saying it's just not me. And these are the medical consequences. As you know, with homocystinuria, you have blood clots, strokes, heart attacks, MI, recurrent spontaneous abortion. It's interesting that I will ask my patients, or they will tell me, like, you know, I haven't been able to have a child, or like I had problems. And it goes back to this. Neurologic issues, as you know, too much homocysteine affects the brain cells in a bad way. Ataxia, neuropathy, microcephaly, scoliosis, anemia. What I want to talk about with anemia is, let me see if I can go back to here. Notice how if you cannot convert the L-methylfolate, or you don't have it, you know, B12 is not working. So why do we check B12 in patients complaining of fatigue, right? Problem with B12 deficiency, macrocytic anemia. What I want people to get out of this is that humans, the body does not live in one concept. We have to integrate everything. What are the causes of MTHFR deficiency? It's in the SNP. We explained that, right? These are variations, abnormalities in the genome. We talk about the phenotype, that there are several genes that can cause the same thing. We still don't really know a lot about which genes cause what, but we're starting to learn. And even the obesity gene, there's 400 of them that is involved in figuring out how somebody can gain weight. Let's talk about the SNP and MTHFR gene, known as the most common one that we see is 677T variant. We replace cytosine with thymine instead of guanine. So instead of CG, CT. It reduces the activity by 35% because of the T allele. The next gene involved in MTHFR deficiency is A1298C. This reduces, or let me just say, adenine is replaced with cytosine instead of thymine. So instead of AT, we got AC. So this reduces activity by 20% because of the C allele. Is it possible to have the two combinations? Yes, and it is additive actually. 35% decrease in MTHFR deficiency with 677T CT, and you add it with the SNP of A1298C, 20%, you will have a 55% decrease in MTHFR deficiency. So sometimes you may not, like I said, you may not feel the manifestations of this condition, but under periods of stress or any kind of toxin or any kind of insult, like a brain injury, you're going to feel it, because you know what? Your brain ran out of gas. It can't keep up with the demand. You have the decrease in MTHFR activity, decrease in L-methylfolate. There's a pop quiz. There's only one gene where you see elevated homocysteine. You just have to remember it's C677T. And the treatment for it, L-methylfolate, you have to give them 15 milligrams. There are cases that we don't, but in general, if you have pure MTHFR deficiency, 15 milligrams is the recommended dose. And the studies have shown if you add it to an SSRI, it's better than an SSRI therapy alone. Why? This is the reason why there's failure. What if you're not making enough of your own serotonin, dopamine, or epinephrine? It doesn't work. Or let's just say you're not going to get the robust effect because there's nothing to keep around, or there's not enough to keep around.